complicated to go into, but we're going to try and show you this. So it stimulates another part of the brain to then activate. So it happens much quicker than you would expect through just synaptic activity. Casanova is one of my dear friends and colleagues, sat beside me at a think tank a few years ago, and he said, there's no inflammation in the brain of kids with autism. I said, what are you talking about? There's inflammation in the brain of kids with autism. He said, no, there's no inflammation. I've dissected 25 brains, there's no inflammatory changes, there's disordered mini-columns. So he's right and wrong, okay? There's not traditional inflammation the way you might think about it, with invasion of white cells and inflammatory reactions. There is immune dysregulation in the brain, but not traditional inflammation. And there is disrupted mini-columns. Mini-columns act like circuits, and I'll show you what a mini-column is. So what he did was he applied magnetic impulses, very slow magnetic impulses. These were repetitive transcranial magnetic stimulations at 1 megahertz. Should be 1 hertz, not 1 megahertz, 1 hertz. Through 12 sessions, and he found dramatic changes in regulatory cells called double bouquet cells, which are immunologically very important cells. So this is a axis. This is essentially a mini column. This is the pyramidal cell, various supporting cells, and the DB cell. And it turns out the DB cell regulates reelin, which is immunologically important, as well as GABA inhibitory activity for the brain. And he found over just 12 sessions, dramatic improvement in kids with autism. Let's explain this slide a little bit. So when I ask you to look at a target, you actually increase inhibition of extraneous input. So you basically focus down through inhibitory effects, not by stimulating your visual cortex, by inhibiting everything else on your target. So this is a control child, or group of children, this is 20, and then when we ask them to target, they increase gamma inhibitory activity substantially, it goes way up. When we ask a child with autism, non-target versus target, it goes the wrong direction. They're not able to inhibit. They don't have that double bouquet inhibitory activity functioning. However, this is their pre-status, and this is after just 12 sessions with slow frequency repetitive transcranial magnetic stimulation, there was a not quite normal, but a pretty dramatic shift towards normal change in the brain that was associated with remarkable changes. So if you look at the repetitive behavioral scores pre and post-treatment, they improved dramatically. If you look at hyperactivity, it trended towards significant, but it was such a small population it didn't reach there. But if this N was 20 and you had similar numbers, it would have been statistically significant. Social awareness trended in the right direction. Irritability got dramatically better. Very similar to the changes that we see with Gc-MAF therapy. So I'm the principal investigator of this study, which is about to start Monday, on the evaluation of magnetic resonance therapy using a different methodology that we think may be superior even to that one for kids with autism. Very complicated, multi-center study looking at MRT, magnetic resonance impulses, so hitting the brain with a certain harmonic. And this isn't going to end the slideshow, but I'm going to shift gears for just a second. And I'm going to show you a video of one of the children that we take care of. This is a nonverbal kid with lots of self-stimulation and self-injurious. He actually has a pad under his shirt because he hits himself so much he hurts himself, so he's wearing a pad. You can see him hitting the pad under his shirt. Non-stop, self-stimming all day long.
Please, buddy.
You're going to see the therapist move in and put, that's the magnet. And we're going to start the magnet therapy. It's 6 seconds of pulses and 54 seconds without. And you can see what happens after 8 weeks of treatment, 2 months.
I got you. Ready?
And no words. He'd been in ABA for 2 years with no progress.
Kid. Oh, that's not a T, it's a D. Kid. Good boy.
So this is about 8 months later.
So say, boy, rat, good boy. Good boy.
So I want to show you, so you can see the side-by-side comparisons.
Rat, good boy. Good boy.
So this next one is actually a bit more difficult to watch. This is an 18-year-old child with profound autism who had some birth-related asphyxia as well and a degree of cerebral palsy, but the primary symptoms are autism-related. It's very difficult. He's very self-injurious. If that's offensive to you, I apologize. You may want to close your eyes if it's too much to watch. But you can see his response to MRT as well. These are all on the BTC website. So. Maybe. You might watch it. While that's trying to load, I'm going to run up to this one above it. This is a higher functioning child. He's been through a lot of behavioral, a lot of medical interventions, but not better enough. Very addicted to the iPad. Has a bit of language. She doesn't use it very often. Doesn't like eye contact. And would prefer to be with her iPad all day. She became a little social butterfly, conversational, pretty dramatic changes over a short period of time. You can see the magnet in his hand, and it's just a handheld double circle, kind of a butterfly coil. And you're going to see the actual therapy initiate. You hear the clicking. The clicking is actually the power of the magnet deforming the coil, causing that click. So the challenge that we had with creating a sham coil was we had to have a coil that would make the same sound and appear to be the same, but not emit any sort of magnetic impulse. So we have a two-sided coil and a computer program that regulates the coil, so when we turn the coil over one way it emits a magnet, and then if the machine says turn it this way, there's just a sham output, and it makes a sound, and it looks like it's doing everything, but in fact there's really none of that. We'll see if we can get this 18-year-old to pull up. May not want to. So what I'm going to suggest is the following. That the primary insult in autism is immunological, probably starting in utero for many of the kids, continuing on through an immunologically threatened environment thereafter because of a primed glial immune system within the brain, and probably their macrophages and mast cells are immunologically primed as well. That to really obtain the ideal results, you need a potent immunological therapy like Gc-MAF or the GoLeg, the oral form of Gc-MAF, combined with, for the more resistant cases, some form of neurophysics application. For me right now, that's MRT, but we'll have the results of the study in 6 to 12 months, and we'll know better the details on the outcome from that. Based on our early observation, it seems very powerful. So if you need to get a hold of me, my email address is drbradstreet@gmail.com. Just my name, drbradstreet@gmail.com. You can call my office. And I hope that this has been helpful, and we do have some time for questions, so wherever they may be. Do you have any questions about this? Hopefully? Maybe? It was so good you didn't need any questions?
Yes. Yeah, it was very nice to hear from you and your ideas. I mean, I've been looking forward to meeting you. I personally have an autistic child who's the first of my children. And now what you said was interesting is just that he has a sister. That the sister is not, at the moment, is not showing the signs, sometimes I see she's banging her head when she's upset with the brother.
How old is the girl?
She's now 1 year and 2 months, but
Okay.
she's not showing any autistic symptoms at the moment.
So, really simple application of this. So what we do routinely every day in my practice is we do ultrasound on siblings. So you saw the twins where one was affected and one wasn't. Big difference in the ultrasound in terms of what's there. So it's very easy, non-invasive. It takes a matter of a few minutes, literally just a few minutes, probably less than 10 total, to get good quality pictures through ultrasound of the subretinal space. And I would suggest screening with either ultrasound, which is very easy and non-invasive, or with MR to look and see if she has increased extra-axial space. But most radiologists have not a clue of what to look for, so they wouldn't necessarily give you the proper study. I know Professor Ruggiero has his ultrasound machine with me, and I have mine, and possibly we can arrange something with Dr. Gardari in our hospital or whatever to try and accomplish that. But it's a very simple process.
Another question I had, sorry, just follow up. My son has been on method B12 for the past year, nearly 2 years now. He's doing very well.
Good.
So would MAF would be an added value to his treatment, or should I leave him where he is?
Okay, so in my opinion, Gc-MAF is the most potent therapy that I've used, and I've used methyl B12. I was part of the original study group with the Mind Institute to start the methyl B12 study that they ultimately published. I think methyl B12 is a band-aid. It doesn't necessarily get at the source problem, which is the underlying immunological dysregulation, anywhere near as potently as Gc-MAF type of therapies do. So at this point, I'm comfortable enough saying that most children with autism should be considered for Gc-MAF therapy by somebody who understands what's happening and how to properly apply it. In most of my kids, even with the Goleg form of Gc-MAF, even though we can give that orally, even that form we typically give through subcutaneous injection. So the cancer patients get it injected intravenously or intramuscularly or sometimes into the tumor. The children with autism, we usually use an insulin needle when you go subcutaneously. I know that another practitioner is using it through the intramuscular route. There's nothing wrong with that. It's just very simple for the parents to give it through the subcutaneous route. The paper that we published, those data were presented with subcutaneous injection using an insulin needle.
Peter, you want to stand up?
Excellent information. Thank you. What about vaccines? Are they sometimes seen as a trigger event for autism? And could that be underlying immune dysfunction? And then we have the catalyst.
So let's just talk. There are a multiplicity of triggers, and vaccines are designed to be immunological triggers. That's why we give them. We're using adjuvants, aluminum, and things to heighten the immune reaction. If you're primed to go in the wrong direction, it would be a further additive insult to a child who may already immunologically be vulnerable to those kinds of things happening. I have enough kids in my practice who've never been vaccinated, who have autism, that it can't be the only answer. It's not just vaccines in the kid. Actually, I have quite a few patients who've never vaccinated their kids at all and still have autism. So there's other stuff going on that we need to be cognizant of.
Thank you.
Yes.
Mr. Bradstreet, first of all, thank you for all your great work and research in helping the kids with autism all over the world. You are a well-known figure. My question for the MRT, is there a criteria or indications in some kids that you give MRT?
A contraindication?
No.
What's the indication?
What's the indications? And also if there are any contraindications.
Okay, so in the research study, we're precluding the use of psychotropic medications and anti-seizure medications. Our experience has been that anti-seizure medications decrease responsiveness to MRT. They are membrane stabilizers. They tend to inhibit the plasticity effect that we're looking for. Seizures per se are not a contraindication in general for MRT treatment, but they're an exclusion in the study because we're trying to shape the study to get the best outcome. We actually have 12 of my patients with seizures being treated with MRT, and their seizure frequency is reducing dramatically. We had one child that had a frequency about every 12 hours having a seizure, that vary between a partial complex to a complex seizure. Hasn't had even a partial complex seizure now in 3 weeks. So MRT may be highly beneficial in that group. Medications may interfere with the results, however.
Doctor, my question is, how do you resolve the fluid in a 2-year-old?
A little bit louder on that? How do I what?
How do I resolve the fluid, the extra-axial fluid, in a 2-year-old? I have 2 siblings with autism, and the third one is 2-year-old. And I'm a little worried about her. I'm following up with Dr. Dardani, and she's just starting to show a few features, delayed speech.
The good news is you have a very good local physician who's, anytime she needs access to any of us, I'm sure she can find us and let us know. But I would follow through with Dr. Dardari. As far as the diagnosis of the fluid, we're more than happy to assist her in learning or teaching her radiology department to do what we do. It's not a complicated technique. Any radiologist can learn to do this technique. But let's assume that the fluid is present. So based on the results that we've been seeing, they're not published at this point in time. It would be another very complicated to get published study because of the difficulty of getting approval in the US for doing studies on Gc-MAF. We are seeing resolution of the fluid over time with Gc-MAF therapy. I'm not going to be in a position to publish that anytime soon. We would have more luck trying to publish that in a research study here in Dubai than we would for the US, actually.
What about steroids?
Steroids are interesting. They really can't be used long-term, and this is not a short-term problem. So there's been some observations of high-dose steroids being effective for autism. Dr. Ches actually published those, where he would give children 10 milligrams per kilogram over a weekend. Massive doses of the pediatricians and the audience like, what? 10 milligrams per kilogram of solumedrol IV? Those are huge doses. He stopped doing that after 2 children died from sepsis. So steroids are the wrong way to manage the immune system. They're anti-inflammatory at the expense of being immunosuppressive. Gc-MAF is anti-inflammatory without being immunosuppressive.
So you would recommend I try Gc-MAF with my 2-year-old?
Gc-MAF I recommend Gc-MAF for most children. Now, I can't recommend it for your child because I don't have a relationship with you or your child. I don't know anything about your child. But I use Gc-MAF extensively with very few contraindications.
Is the lady beyond Peter?
That would be Dr. Dardar.
No, there you go.
How many of you know Dr. Dardar? She's the head of pediatrics at what hospital? Okay. Okay, good.
Thanks, Dr. Bradstreet, for giving me too much credit more than I deserve.
No, I actually enjoyed working with you over the years. So.
I come here with a lot of questions from a lot of parents. You answered some of the questions about treatment and results in older patients, because that was one of the questions I didn't answer. The other questions were, what's the long-term side effect? Should we worry about long-term autoimmune diseases in these kids if we put them on long-term Gc-MAF? And the other question which you answered, is it a long-term thing? And you said yes, 70%.
Seems to be in most cases. So should we worry about long-term side effects? Of course. Interestingly enough, we're now 3.5 years into it, and quite the opposite. We're not seeing immune dysregulation over time. We're seeing, in fact, ease of treating for most patients, not all, but for most patients, their gut immunological issues are better, their chronic other immunological issues are better. You see their eczema resolve. I don't know what your experience has been in observing eczema to resolve with Gc-MAF, but usually within the first 3 months, eczema is gone. So it appears to be immunologically beneficial rather than upregulating. It is a human-derived GC protein. There is some risk of antigenicity to it, but I think that since it's a natural occurring protein, that's pretty small.
And then, what's your preference as far as oral versus injectable? Is it case by case, or is it?
My preference is to start with injectable, and the reason for that, unless it's just not practical in that family for whatever reason. I have some parents that are needle phobic and they're not going to get near giving their kid a shot, and that's not going to happen. So in most cases, because of my ability to consistently manage the dose, I typically start off with injectable. After they're stable and I'm going to be in that longer term sort of care, I try and switch the kids over to oral. Now, interestingly enough, I have and I can't explain this, but I have a subpopulation of kids that do extremely well on oral Goulet, which is the oleic acid version of GcMAF, and then a group that don't seem to respond appropriately to that. And then I have another group that didn't respond to GcMAF, that when we switch over to Goulet in either injectable or oral form, do much better. So I don't have a clear understanding of why that's happening yet, so I don't have a real preference. I typically start kids out on GcMAF because I have 3.5 years of experience with that, and then downstream I'll get more creative depending on the circumstances.
We've got time just for one more.
Just one. Other than the high fever as a short-term side effect, do you see any major side effect behavior?
High fever is rare. If you look at the paper, most of the temperatures were 39 or less. Like one was 39.5, but it's pretty unusual to see high fever with GcMAF, the way I do it. Now, I start with very low doses. Some of the kids are getting sub-nanogram doses to start with, so very small amounts initially. And when we titrate up slowly, I don't see a lot of side effects. I don't have a lot of hyperactivity. In the situations where parents have dosed on their own, they start off with much higher doses. I do see a lot of hyperactivity initially. And I agree that as you get higher and higher in the doses, you tend to get more and more response. But their immune system initially is very fragile. So I'm very cautious with how I start off with them.
I'll leave the time for other questions.
Last question, please.
Okay, can I ask?
Yes.
How can CT markers measurement aid us in deciding to use GcMAF or not, especially CD8 and CD57?
I really wish there was an ideal immunological marker to predict GcMAF response at this point in time, but I don't think the GcMAF response is limited to the immune system. So I don't think that the CD differentials are going to give us the kind of picture that we want to say yes or no to GcMAF. I think that because of its direct effect on neurons, assuming there's no contraindications and you're cautious with your dosing, you should proceed with GcMAF in most cases because it may be beneficial directly to neurons themselves. So I will be around. But before we close, I think Professor Ruggiero and I are interested in helping some of you to learn ultrasonography. And we had initially envisioned a 2-day course, which I think is maybe a little bit too aggressive for this audience to get started with 2 days of commitment. So I was hoping to see him, but I don't. Okay, so I'm assuming what we can do, I think the original price was $5,000 for CME treatment, our testing, training, and certification. We can probably drop that by half to $2,500 and treat and train up to 10 of you tomorrow on that. So how many of you would be interested in getting certified in ultrasonography? Yes? No? Maybe? Not enough. Okay, so we'll probably cancel the course then. That's fine. Thank you very much. I appreciate your time.
Okay, thank you, Dr. Bradstreet. Our next speaker will be Dr. Noakes. There is an autism breakout session